Hello everyone, today I am going to discuss the role of echocardiography in intensive care unit. Echocardiography nowadays is the first line tool for assessing any patient in ICU, as we all know. It's non-invasive, safe, widely available, relatively inexpensive, and the most important thing, it's repeatable. Useful for anatomical, functional and hemodynamic assessment of the heart. Can be helpful in diagnosis as well as in therapeutic aspects. There are mainly two types, transthoracic and transesophageal echocardiography. Mostly we as an intensivist use transthoracic, and the transesophageal echocardiography was used to done by the cardiac anesthesiologist in OR. Now what are the clinical scenarios where we will use echocardiography? When the patient is hemodynamic unstable, when we are suspecting left or right ventricular failure, when there is a high suspicion of acute coronary syndrome and its complications, the patient is hypovolemic, acute valvular dysfunction, infective endocarditis, to rule out cardiac tamponade, pulmonary embolism, and but not the least, it's the acute dissection and rupture. It's a life-threatening thing. We should detect it early. Now, in my lecture, I want to discuss two things separately. First, mainly what are the views, what are the windows by which we can measure the parameters, and then I will discuss something about the use of echocardiography in critical care. So to use echocardiography in bedside, there is a special probe is there, that is the phased array probe with a small footprint, so that we can adjust it in between the rib cage. Patient should be in supine position, preferably if possible in left lateral, and indicator of the probe should be on the right side of the screen. Now how to use the probe? It's more of a practical thing, and as you all know, we can slide the probe, we can rotate the probe, we can rocking the probe, so that we can identify the structure in a better way and best possible view can be obtained. And these are the things. And now coming to the planes, mainly the short axis and long axis view. Axis, when the short axis, the heart is cut on anterior posteriorly, and the long axis heart is cut from apex to base. Now coming to the different windows, the parasternal windows, that is the C1 position, left, third or fourth intercostal space. It is not fixed, but we have to obtain the picture that I will show later. And long axis when the transducer marker at the right shoulder, and short axis when the transducer marker is towards the left shoulder. Now coming to the apical window, it's where the apical impulse is there, fifth or sixth intercostal space, footprint towards the right shoulder and fourth chamber, and it can be obtained as a 5-chamber view after just tilting a probe a bit so that we can open the aortic valve. Coming to the last, that is the subcostal and the suprasternal window. Subcostal window is very important. It is below the 𝑬𝑫𝒰𝑪 process, and footprint towards the left shoulder, and for IVC, the transducer marker at the 6 o'clock and the cardiac presets, or in the 12 o'clock at the abdominal vaginal presets. Suprasternal is not very useful or very commonly used in day-to-day practice, but it is very helpful to identify any type of aortic pathology. Now, just before I go into details, we should keep in mind that we should obtain the correct view or correct picture, correct frame, so that we can identify the structure in a better way and we can measure the things. So for left parasternal long axis view, when the position in the C1, that is a parasternal third or fourth intercostal space, transducer marker pointing towards the right shoulder, we should obtain this kind of view. Then only we will be able to calculate the things. This is the LV, this is the RV, this is the AV, aortic valve, this is the LA, this is the mitral valve. And in the same plane, if I rotate the probe to a 90 degree and pointer now towards pointing to the right shoulder, we will obtain this view. This is the parasternal short axis view. Look at the donut image of the LV and the circular image, circular area. LV should be like this, and the muscle mass is there, and the RV is like this, the muscle mass is less. So you should obtain this view, then we will be able to calculate. Now parasternal short axis view, it can be if I tilt my probe from apex towards base, there are 3-4 different kind of images will be there to identify different structure and different pathology. So to start from, if I place it in the apical place, So it is anterior wall, this is the lateral and posterior wall, this is the inferior wall. Just after tilting the probe a little bit, we will obtain a mid-papillary view. This is the best view to identify the EF in a eyeballing manner, so that all the walls are contracting appropriately or not, and 1/3 of the volume is decreasing or not on contraction. If it is there, then its contraction is okay. If it is less than that, the contraction is not up to the mark. Tilting a probe a little bit more, we will obtain the mitral valve either in a closed position or in open position in the fish mouth area. This is the thing. And after that, we will obtain the view of the aortic valve. That is, we will obtain the Mercedes-Benz, classic Mercedes-Benz sign. Now, coming to the apical four-chamber view, the most important thing is the shape of the ventricle. The LV will be elliptical and the RV should be more or less triangular. If it is not there or there is any change in the shape, it is pathological. And in this view, we will be able to identify the shape, the dimension, contractility, whether there is any regional wall motion abnormality is present or not, whether there is any valvular pathology is present or not, valvular regurgitation is present or not, we can identify in this view. Coming to the apical 5-chamber view, just tilting my probe a little bit, we will open the aortic valve so that we can identify the LVOT, that is left ventricular outflow tract, and it is very helpful to determine the stroke volume. Now coming to the subcostal or IVC view, useful in determining fluid responsiveness, it is very important to place the cursor in such a manner that it is just beyond the joining of the hepatic vein towards the IVC, and just when the IVC entering the RA, this is the area where we should measure the IVC diameter, and there is a variation in the inspiration and expiration, and depending upon that we can identify or we can gauge a little bit about the right atrial pressure. If the IVC diameter is less and the respiratory variation is high, that is more than 50%, so definitely the right atrial pressure is less, so most likely the patient is hypovolemic, whatever may be the cause. And if it is IVC diameter is more than 2 cm and the variability is less than 50%, so definitely the patient is not requiring fluid, the patient is in a fluid overloaded state. Now the calculations we should do. LV systolic function, definitely it's very important. It can be done by different methods, but it's better to do it in this manner, just to identify the LV end-diastolic diameter, LV end systolic diameter, and depending upon that, LV EDD minus LV SED by LV EDD is the EF. Now coming to the RV systolic function, that is the tricuspid annular plane systolic excursion. It is very important to identify RV dysfunction, so that we can identify whether the RV failure is going or not, whatever may be the cause. We have to place the cursor just where the tricuspid valve is attaching, and with that we will press the M mode, and if the excursion is within 25 to 35 millimeter, it's normal, and if it is less than 17 millimeter or 16 millimeter, it is abnormal. That means the RV systolic dysfunction is there. Coming to the stroke volume calculation, it is very important in our day-to-day practice, so that we can identify whether the patient is will be benefited from any fluid or not, depending upon this thing. So first we have to obtain the parasternal long axis view. So we will be able to identify the LVOT or LV outflow tract, and we will measure this distance. It is the LVOT diameter. We will divide it by 2, so there will be the LVOT radius, and depending upon that, the cross sectional area will be pi r square. And after that, we will place the cursor in a 5-chamber view just above the aortic valve. It will determine the flow of the RBCs in each contraction, and it will be traced like this. And then this is the term. This term is called VTI, velocity time integral, and we can identify stroke volume just by multiplying the VTI of LVOT with the cross-sectional area of the LVOT, so that we will be able to identify the stroke volume. And to measure the cardiac output, we have to multiply with the heart rate. Coming to the diastolic function, this is another thing. We will place the pulse wave Doppler over the mitral area, mitral inflow tract, and the two waves will be there, the one E wave and one A wave. E wave stands for when there is rapid filling phase of the start of the diastole, and A wave stands for the atrial creak or atrial contraction at the end of the diastole. And depending upon these two values, we can identify whether the patient is having any impaired relaxation, whether the patient is having any restriction because of the constrictive pericarditis, or whether it is the diastole dysfunction is there but it looks like a normal. So what is normal? Normal is when the E wave velocity by the A wave velocity is between 1 to 2, the deceleration time of the E wave is less than 160 millisecond, and the intraventricular relaxation time is within 70 to 90 millisecond. If it is there, all three things are there, the patient is having a normal diastolic function. If the E wave velocity decreases, okay, that means the patient is having an impaired relaxation. So the E by A ratio will be less than 1 and deceleration time will be definitely more than 160. If there is a E by A ratio is more than 2, then there is some restriction is there because of the maybe because of the constrictive pericarditis, and in this patient also high volume of fluid will be very detrimental. Coming to some more pathologies, if we find anything like anechoic shadow just outside the heart and within the pericardial cavity, it signifies there is a fluid. It can be any type of fluid, it can be blood, it can be serous, or it can be anything, it can be pus also. But not every pericardial effusion is significant. A patient who is having any chronic kidney disease can have some amount of pericardial effusion, that is not doing anything wrong, and it's quite normal to have pericardial effusion in a patient of CKD. But the posteriorly, if it is more than 2 centimeter, then it is definitely significant pericardial effusion, we should drain it. And if it is circumferential and if it is causing any difficulty in the RV filling, then it is also significant, that can lead to tamponade. The tamponade physiology may be on the verge and we should take urgent care of that thing. I will definitely describe the details of cardiac tamponade in my later slide. Now this is the cardiac tamponade. Look at the RV collapse during the early diastole and look at the ivesive plethora. If both things are there and the patient is having hypotension, we should be very cautious whether the patient is having any cardiac tamponade or not, and we should drain it or we should inform our cardiology team to look at it in an urgent manner. Now, what are the features in echocardiography which will suspect the patient is having cardiac tamponade? There will be swinging of the heart within the fluids. There will be early diastolic collapse of the right ventricle and less diastolic collapse of the right atrium. Abnormal ventricular septal motion will be there, and respiratory variability of the mitral inflow will be more than 25%, and the respiratory variation in the ventricular chamber size will be there, and the most important thing, the IVC will be full. Now coming to the another critical situation, that is critical condition, life-threatening condition, that is the pulmonary embolism at bedside. If the patient is not stable enough to shift to the CT scan room for a CTPA, we have to identify pulmonary embolism in a great suspicion in a patient who is having hypoxia along with shock which happened very rapidly. So just putting in the parasternal long axis view, if the enlarged right ventricle is showing in the parasternal long axis view, or in the apical fourth chamber view there is a dilated RV along with the RV and LV by LV ratio is more than 1, that means the RV diameter is more than the LV. So definitely the RV overload is there, maybe pressure, maybe fluid, particularly in this case it is pressure overload. And the McConnell signs is there, that is this is the pre-wall movement of the right ventricle is there, and it is very pathognomonic of pulmonary embolism. And the flattened intraventricular septum, so the LV shape will look like a D. I have shown earlier that LV should be like globular or circular, but right now if the LV is looking like a D-shaped LV, so that the RV pressure is more, that's why the septum is going down on going towards the LV, and it is signifies the pressure overload of the RV. And in the fourth picture when the IBC is full, and in the sixth picture if you can identify any thrombus is there, and definitely in the G picture there is the decreased tricuspid annular plain systolic excursion that I already told you. If it is less than 16 or 17, that means the RB dysfunction is going on. Along with the patient is having hypoxia and hypotension, so there is a high possibility the patient is having a PE. Now, echocardiography can diagnose from symptom to the diagnosis or pathology. So whenever a patient is having dyspnea, there are multiple possibilities. Just with the help of the echocardiography, within 5 to 10 minutes we can diagnose whether the patient is having a grossly hemodynamic unstable pulmonary embolism is there or not. We can identify that. I have discussed in my last slide. Whether the patient is having acute valvular disease, maybe because of the patient is having any acute. If there is acute valvular pathology is present or not, we can identify with the echocardiography. If there is a cardiac tamponade, I have already discussed, we can identify that led to dyspnea because of the heart fluid overload of because of the pulmonary edema. And if the patient is having hypotension, so we have to identify whether there is a severe systolic dysfunction because of the myocardial infarction, myocarditis, or whether the patient is having an LV underfilling because of the hypovolemia, because the patient is dehydrated, or patient is having an ongoing hemorrhage. We can identify with the echocardiography in a matter of 5 to 10 minutes. Now, just a brief things about the fluid responsiveness. As we all know, whenever the myocardium fiber is stretched, it will contract in a vigorous manner. That's the famous Frank-Starling curve. So in a certain, this chart looks like this. If we place any point of time and we could place a heart in any point of this curve, and if we give a preload challenge, depending upon the condition of the myocardium or depending upon the condition of the heart, if it will signify whether the patient will be benefited from fluid or fluid will be harmful for that patient. How? Look at the first picture. Look at the upper curve rather. If the patient's heart is in this condition and we will give a preload challenge and the patient is heart in the steeper portion of the curve, so some amount of fluid or some amount of preload challenge will increase the stroke volume in a significant way. But the same preload challenge, if the patient's heart in the last curve, when the heart is having a very poor ventricular systolic function, and we will give a preload challenge, the same amount of preload challenge will lead to a very minimal change in the stroke volume. That means further fluid in this patient will be detrimental. We can identify with the help of the echocardiography just by looking at the diastolic function also. Along with the definitely we have to identify the systolic function first. Now VTI variability, it's the same thing. If the patient is having any variability after fluid challenge or a respiratory variation is present, if it is more than 20, the patient is having any fluid deficit is there, and the patient will be preload responsiveness. We can identify in a patient who is in shock just with the VTI variability with the respiration or after fluid challenge. If it is there, we will administer fluid and definitely the patient will be benefited. Now coming to the assessment of the shock patient, this is the famous article from the anesthesiology literature, and they have divided the patient with a shock in 3 clusters. Just I will go by this flowchart, and they have amalgamated echocardiography along with the lung ultrasound, the last third pictures. Okay, so let's start. If the cluster 1 patient is having small or normal cavity, increase or normal global contractility, so there is no problem with the contractility. It can be a phenotype 1, whether the cavity is small, IBC is flat and the lung is A pattern, patient is hypovolemic. If the phenotype 2, cavity is normal but collapsible IBC is there and lung is A pattern, so it's a distributive shock. That means the patient is having a septic shock. The last phenotype 3, when the LA dilatation and LVH with a thick septum is there but the collapsing IBC is there, that we along with the A pattern lung, so this patient is having shock because of maybe because of the diastolic dysfunction, hypovolemic, distributive shock. It can be a combined thing. Coming to the second cluster, when the enlarged LV or RV is there along with the decreased global contractility, it can be LA-LV dilatation, phenotype 4, along with the plethoric IVC, along with the lung pattern is B, or it can be biventricular enlargement dilatation along with plethoric IVC and a B pattern lung. So it's a pump failure. There is high pressure pulmonary edema is going on because of the B lines is showing, and that's why we need to worry about this, because the patient will be fluid is harmful for this patient. Cluster 3, isolated enlargement of the right ventricle, increase or normal LV contractility. If the RV dilatation is there, but there is no RVH along with a plethoric IVC and AV pattern lung, it is acutely isolated RV failure. It can be a pulmonary embolism or it can be ARDS. But if the RV dilatation is there along with RVH is there, so it's a chronic pressure overload. So it can be acute and chronic isolated RV failure. It can be because of the pulmonary hypertension. So to manage this kind of patient, for cluster 1, definitely fluid is indicated, because the small cavity, when there is small cavity, fluid is the treatment of choice. When the LA is dilated, LVH plus thick septum, along with that, then also we will give a certain amount of fluid. But when the patient is having distributive shock because of the vasodilated state, along with the fluid, we have to start vasopressors also. Coming to the cluster 2, when the LA and LV is dilated or biventricular dilatation is there, we will give a smaller amount of fluid challenge. Look at this fluid challenge, 10 ml per kg. We will give a smaller amount of fluid challenge for this patient, and we will observe, and we have to give ionotropic agents because the patient is having a cardiac pump failure or cardiogenic shock. Now coming to the cluster 3, when there is no RV dilatation is there, but when there is no septal shift, so we can give a fluid challenge and we have to add vasopressin and ionotropic agents. But if the septal shift is there because of the pressure as well as the volume overload, the fluid is contraindicated. We will not give any fluid to this patient. We will directly go with the vasopressor along with the ionotropic agents. Now just to conclude my talk, bedside echocardiography should be used regularly to assess critically ill patient. We have to obtain the best view possible, then we should start measuring. Gross systolic function of the heart to be assessed in all patients of the ICU, so that in later case we can identify whether there is a drop in EF or not, or we can identify early that the patient may be benefited from fluid or not. All hypotensive patients should be assessed by echo to know the reason for hypotension. Fluid responsiveness to be judged by echo as per the protocol, but more important thing, response to fluid therapy should be observed. Not all hypotensive patients need fluid. Some may need fluid removal also. Echo will guide us, and we have to rule out the 3 dangerous things, that whether the patient is having any cardiac tamponade, pulmonary embolism or aortic dissection or not. Thank you.